I am currently a core surgical trainee at Lewisham and Greenwich Trust, and I'll be talking to you today about tibial plateau fractures, tib and fibular fractures, and patellar fractures in a bit more detail. So the objectives of this session is that we're able to identify common presentation of tibial fractures, how to examine these injuries when we see them in the emergency department. We'll talk about the key features of patellar fractures, tibial plateau fractures, and tibial and fibular shaft fractures. We'll talk a little bit about the classifications and how they can be helpful in describing injuries and guiding treatment. We'll talk a bit more about the radiographs of the lower limb and interpreting them, as well as showing you the fracture patterns on x-rays, and acute management in the emergency department. We'll then go on to talk about the operative management of these fractures in a little bit of detail to develop an awareness of those two. Okay. So just starting off, quite commonly this is high energy, typically in young males, car accidents, road traffic collisions, etc. Or generally elderly females who suffer from osteoporosis, and those tend to be low energy impacts. Particularly with patellar fractures, it's usually direct impact or falling directly on it, or varus and valgus loading of the joint of the knee joint causing tibial plateau fractures. Again, as we said, risk factors are osteoporosis specifically. These patients typically present with acutely painful swollen knees or legs following trauma, and they have difficulty weight bearing, but not all, and we'll go into that in a bit more detail in a moment. So first off, when you see a patient, you're going to take a history and you're going to examine. So the first part of our examination is inspection. We're looking for joint swelling and where the swelling is along the leg. So is it specifically just isolated to the joint, or is it the whole leg? You also want to look at the leg circumferentially to look for cuts and abrasions, which may suggest that it's an open fracture. The picture you can see the normal knee there on the right hand side and a very swollen knee on the left, and that's what you may see in these fracture patterns. Next, you would palpate, particularly in the context of fracture. This can be painful, so you should be gentle, but it's quite useful in those where it's not clear if there's definitely a fracture or not. So you initially can palpate for effusion, including the Patellar tap test, which you can see demonstrated in the picture. You then also palpate the joint line for point tenderness, which may indicate specific areas for fracture. You should also make it good practice to palpate all the compartments of the thigh and the lower leg to assess for compartment syndrome, which is particularly a high risk side effect from these fractures. Assessment of movements is typically what we do in patients who present with chronic knee issues or leg pain. This can be difficult in fractures, but some patients, particularly those patients with patellar injuries, it's a very useful examination, particularly straight leg raise. These patients, especially with patellar fractures, lose the function of the extensor mechanism of the leg, and so are unable to straight leg raise or lift their leg off the floor against gravity. Neurovascular assessment. Again, very important. I've included a diagram here of the arterial and nervous supply to the lower leg, so to give you a bit more context. I will put this slide up following the different fracture patterns to isolate and really point out which bits are more important for which fracture pattern. As you can see demonstrated in that picture, the popliteal artery is of specific significance for those fractures involving the knee joint itself. And then more distally, you see the dorsalis pedis artery and the posterior tibial, and you can see their origins there. So we'll start off with going over patellar fractures. These are usually from direct fall onto the knee itself, and they can present in all of these types of ways. We'll look at some x-rays now. So quite commonly you may just see a swollen knee. You may not feel a gap because of the bleeding that can come from having a fracture of the kneecap. If they present late, you may be able to palpate a gap. So looking at these x-rays, the most useful views for these patients are an AP, which is an anterior to posterior x-ray, a lateral, which we can see, and a skyline view, which is specific to look at the patella directly on. Okay, can you guys see my mouse? Looking at the AP, you can see that it's a very comminuted fracture on this view. There's lots of pieces. Again, on the lateral, you can see lots of fracture lines. Okay, and these would guide to show you the type of fracture, but the management is pretty similar for all of these, and we'll talk about that. Now, the Skyline View is not the same as the fracture on the left, but it is useful to see. You can see exactly where the fracture lines go through. You can look at any injuries to the femoral condyle there. You can look at any loss of joint space or osteoarthritis, which may suggest that it's slightly abnormal, and it will all guide your surgical management. So the acute management in the emergency department, as we said, x-rays are the most useful thing. The next thing would be immobilization. You can do an above knee back slab with the foot free, or quite commonly, which is more comfortable for the patient, you can do something called a cricket pad splint. And this is simply just a splint that keeps the leg in full extension, and they can actually weight bear with these fractures. Elevation is always important for analgesia. It helps the swelling come down, as well as giving them medication for analgesia. They should have regular neurovascular assessment, though specifically for patellar fractures, there aren't particular vessels at risk or nerves at risk. You want to assess the common peroneal nerve, because sometimes there can be injuries to other parts of the knee, and they may result in motor loss, which is foot drop, or loss of sensation, so always check that. VTE prophylaxis for patellar fractures is probably dependent on the consultant. Some feel that it's important to give, and most would say, yes, actually, it's more beneficial to give VTE prophylaxis to prevent DVTs in these patients. So looking a bit more at operative management, usually this is for patients where there's a gap of 1 centimetre or more between the two poles of the fracture. This is one of the most common surgical fixation techniques that we use, called tension band wiring. And it involves, as you see here, the AO picture on the left shows where we put 2 K wires to hold the fragments together. And then we use a figure of 8 pattern with wires to put tension on the fracture and hold it together to make it rigid structure and restore the extensor mechanism. Okay. So now we can talk a bit more about tibial plateau fractures. These are a lot more complicated. They're typically high energy fractures. You get them with varus or valgus loading, and that can depend on the type of fracture pattern that you see. The picture I've got here is that of the Schatzka classification system, which we use quite commonly in clinical practice. It helps guide our management as well as mainly our surgical management. Okay. So they are listed by grade from 1 to 6, and it's usually dependent on how difficult that fracture is to fix. The start of it, so these by definition are intra-articular fractures affecting the knee joint, and they make the patient much more susceptible to developing knee arthritis if the joint line isn't restored with surgical management. Okay. So Schatzka type 1, as you can see here, is a lateral condyle. So it's on the outer part of the knee, and it's a split fracture where the fragment has just come off. Okay, and that will just be put back on and it can be buttress plated, but we will talk about that a bit more later. Schatzka type 2, that is where you have a split and also a depression within the joint surface there. So it means not only has a part of the lateral condyle come off, another part of it is also being pushed down and crushed. So that would need to be elevated later. A Schatzka type 3 is simply just a depression where the joint surface has been pushed down by loading from the femoral condyle when there's forces. Schatzka type 4 is a split of the medial plateau. Okay, the 4 to 6 are quite severe complex injuries, and they're usually related to vascular issues, especially popliteal artery, and we'll talk about that next, and I'll bring back up that slide about the arterial supply of the leg. It's very important in these patients to document initial neurovascular status and keep checking it. The reason for this is considered to be a fracture dislocation type pattern, and those are high risk for vascular injuries. The popliteal artery lies quite close to the medial condyle anatomically. Schatzka Type 5 is a bicondylar tibial fracture, so that's both where the lateral condyle and the medial condyle have come off. And the Type 6 is where it's just in pieces. There's a complete dissociation between the metaphysis and the diaphysis. Okay, so the joint surface is completely away from the shaft of the bone, and these are the most complicated. So you can see here, this is just a picture I grabbed off Reddit. This gentleman has been in a road traffic collision, and you can see his leg is significantly swollen both in the thigh and the knee. Okay, this gentleman would be unlikely to be able to weight bear coming into the department, and it would be acute pain. Okay, so I've got a few x-rays here to show you the variation in what you can see. What we have here on the left, you have a Schatzka Type 1, where there's just a lateral split here. You could then see more complicated split depressions here, which is Schatzka Type 2, but this is quite a nasty fracture and still would be difficult to manage. And then you have a Type 6 over here on the right-hand side, where there's a fracture across the metaphyseal-diaphyseal junction. The medial condyle is completely off. This x-ray is actually slightly rotated because the fibula is behind the lateral condyle of the tibia there, but it's still very complicated. You can see there's also a part of the medial joint line there completely off. Okay, so these would be quite easy to pick up. You can see that the joint line is quite damaged and displaced. CT imaging would be important for these to establish specifically the fracture pattern, and can be useful for operative management. But let's talk a bit more about those fractures which were a lot more subtle and you may not see. So you can see back on the left, there's a very slight split. It can be quite subtle. It's important to note that bones bleed, and the fat content of blood from the bone is quite high. So you may only see a knee effusion from bleeding into the joint from the fracture, and something that we call lipohemarthrosis. And this would be a suggestion that there is a bony injury, despite you not being able to see it on the radiograph, as we can see here. So the best way to do this is a lateral film with the patient lying supine, and it forms a fluid level within the joint, which is what the arrow is pointing to there. And what you would have is a level of serum and fat, with the fat floating. Okay, if you have this but you cannot identify a fracture pattern, further imaging is usually required, and I would treat this as a tibial plateau until proven otherwise. Okay, so immobilization, and we'll talk a bit more about that now. So the acute management of tibial plateau fractures. Again, as we said, AP and lateral radiographs are very important. I would do an above knee back slab for these patients. Okay, a back slab is where you put plaster along the back of the leg. And the reason that we say back slab for acute injuries is that if you do circumferential plaster, which doesn't stretch, you reduce the amount, when they swell, you constrict that and you can create a compartment syndrome. The reason I say 30 degrees of flexion, most patients aren't able to fully extend their knee, and if it's at 30 degrees, it means that they can mobilize if needed without the foot getting in the way on the floor. Every time you do a back slab, whether it's redone or later down the line, you should always do repeat x-rays to see if you've moved the fracture. Okay, these patients should be non-weight bearing. They should keep it elevated, and analgesia is very important. These are very painful fractures. So we say again, regular neurovascular assessment, particularly in medial injuries. You should make it common practice for all fractures, but specifically these, to document the pulses of presence or absence and compare it to the normal side. Something called the ABPI, which is an ankle brachial pressure index, is useful for these patients. If it is abnormal or different compared to the other side, you should consider doing CT angio. And actually, nowadays, most centres would say if there is a medial plateau injury, then you should go directly and do a CT angio anyway to tell us definitively if there is popliteal artery damage. It also provides a good baseline if these pulses then disappear later down the line, and VTE prophylaxis, as we said before. Okay, so here you can see the popliteal artery gives off its supply to the fibular and peroneal artery and the posterior tibial, as well as the anterior tibial artery, which passes anteriorly and gives off dorsalis pedis. So these patients, it can be difficult to feel the temperature. First off, temperature difference is important. In a cold foot where a patient's been lying outside, where they've had trauma and it's taken them some time to bring them to the hospital, they may have cold peripheries, and it may be difficult to feel these, and that's where Doppler can come in handy. You can do a Doppler in department and see if you can hear a pulsatile waveform, or you can do the ankle brachial pressure index, which you need a Doppler for anyway. Okay, all vessels will be affected if there is damage at the popliteal artery region in the popliteal fossa, which is what would be affected in these injuries. Okay, so operative management. There's a couple of things that you can do for these patients. Patients will have open reduction and internal fixation. So this is with buttress plating and long screws. I've shown you a picture from the AO website which demonstrates how we would do that, and then you can see it in practice in the x-rays on the right hand side. So this patient, I'll just point out there's fractures along here. Okay, and they've put long screws across the tibial plateau to hold it in place and buttress it all from the lateral side. Okay, and this is a common fixation technique that we use for these patients. Here we can see an external fixation device. This is a ring external fixator. This is where you see those patients who have walking around with a frame on their leg. This is something that we would use for very complex fractures, which require a lot of reconstruction, or for those patients who have an open fracture and are at risk of infection. We don't want to put metalwork, internal fixation metalwork, into an injury that has been exposed to infection, because that means that it's very hard to treat infection on internal metalwork because it creates a biofilm. So if we're worried about that from the outset, we should do external fixation, and that generally will stay on longer. So these frames can stay on for 3 to 6 months. Okay, now we talk about tibial shaft fractures. These can vary in what you see on X-ray. Generally, the treatment is very similar for all of them. This is the AO classification system for how to identify and describe these fractures. And so you have simple fractures where they're just a 1-part or 2-part fracture, and you describe them by the pattern. So you have spiral, oblique, and transverse. The larger the surface area of the fracture, the more callus that will be thrown off and the more likely it is to heal. Okay, you see in the 42B, you have multiple parts there. They can be wedge fractures, and they can be associated with both tibia and fibular fractures. These are a bit more complex to fix. And then you have the even more complex fractures, highly comminuted, lots of pieces. They can be very irregular, and it can be difficult to fully restore the original anatomy. Okay. So here we've got some radiographs. We've got AP and lateral again, as we have previously. Here you can see that the tibial shaft on the left-hand side is completely displaced and off-ended, as is the fibula. So here we have the point of there'll be leg shortening and the compartments are at risk. Okay, so the treatment will be to continue to check the compartments of the lower leg, and there's 4 of those. We'll talk about those in a bit more detail, and to restore the height of the leg. Okay, and that's important for function. You can also see that there's an angulation on the lateral, which would also need to be restored. Can everyone mute their microphones, please? On the right-hand side, you can see a much more comminuted fracture. There's multiple segments there. There's very small pieces and very large segments, and a high fibular fracture. I'm not going to talk about the management of fibular fractures in too much detail because they're going to be covered in another talk, but generally they'll be fixed if there's a shortening of height or if it's close to the ankle joint. Okay, so this is how you will see them in A&E. These are high injury mechanisms. You may see open fractures. These are particularly important to look at. You see on the right-hand side just a small abrasion. It may be an in-out injury where the bone has poked through, or it may be something going from outside in. Regardless, this is treated as an open fracture, even for cuts in the skin as small as this. On the picture on the left-hand side, you can see the bone sticking out. This is a dirty injury. There's been exposure to infection, and so these need to be managed in an appropriate manner. As you can tell, there's likely to be a lot of damage around the soft tissue around the fracture, and we need to assess vasculature. The arteries go along close to the tibia, and so it's important to check distal pulses and the temperature of the foot to ensure that they are intact, and if they are not, you would need to involve local vascular surgeons. Okay, so acute management of a simple tibial shaft fracture. We're not going to talk about open fractures at the moment. AP and lateral radiographs, an above knee back slab, 30 degrees of flexion if you can achieve it, and repeat radiographs after the application. Some may attempt to add some traction to manipulate the fracture to reduce it. If they're highly comminuted, this probably won't make a difference as you try it and keep the leg in the most neutral position you can, and include the foot in your back slab. The point of an above knee back slab in this situation, similar to forearm fractures, is to also eliminate rotation. Okay, and that 30 degrees of flexion helps to eliminate rotation of the tibia and fibula. If the leg was completely straight, even though they're in a back slab, that leg would still be able to roll, and that would displace the fractures more. They should be non-weight bearing. They keep their foot elevated, and by elevation we mean above hip height. Okay, too high can also be damaging, and that increases the risk of compartment syndrome as well. Lots of analgesia. These are painful injuries, and regular neurovascular assessment, as well as VTE prophylaxis. Okay, so going back to our previous examination slide from earlier in the talk, you can see the fibular artery, the peroneal artery, and the posterior tibial. You also have the anterior tibial artery, which runs very close to the anterior margin of the tibia. Any of these three can be damaged in such high mechanism injuries, and so you will then see a diminished pulse. If you have an absence of dorsalis pedis relative to the other side, then you can assume there may be an anterior tibial artery occlusion, or there can be vasospasm, or there may be complete transection. A loss of the posterior tibial artery is from damage to the posterior tibial artery higher up, more proximally. Okay. Compartment syndrome is something that we worry about quite a lot for patients with tibial shaft injuries. It is more likely if there is both bone injury. Now, some people would say that if you have a highly comminuted, highly displaced fracture, the fascial compartments are disrupted by the injury, and so compartment syndrome is less of a risk, but you cannot assess this clinically, and so all patients should be treated the same and should be regularly checked for compartment syndrome. Okay, compartment syndrome is an increase in pressure of the compartments within a closed space, so the fascia itself does not stretch, and so the pressure rises and occludes first venous return and then arterial supply, and it can result in irreversible damage and loss of those muscles in that muscle compartment, which is a significant thing for usually the young patients that suffer from these injuries. Okay, it's an orthopedic emergency. Time is of the essence, and we should try to operate on those that are clinically suspected of a compartment syndrome in 12 hours. Okay, the 5 Ps are generally what we use to identify or clinically show the clinical signs of compartment syndrome. Some people will tell you it is pain, 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 pain. Okay, and these patients will be screaming in pain out of proportion to the injury that you see in front of you. Okay, opiate medication, morphine will not touch this pain. Pain on passive stretch, so this is where you may move, you can stretch their compartment, so you can move the foot and see if that is painful for them, or even just further extension of the toes can cause patients like this pain. All right. Late signs are pallor, paresthesia, and pulselessness, which suggests that the pressures have risen to a point where the nerves and the blood vessels are threatened. Okay. It is likely that if you have these signs, there is already irreversible damage happening in those compartments. You can see on the diagram, there's a picture of the 4 compartments of the lower leg. You can see that they're closely, most of them are closely associated to at least the tibia and fibula. Okay. I've also got on this diagram where you would do a fasciotomy incision. Okay. And the aim is to release these compartments, make an opening in the fascia to allow the pressure out. Okay, and these will often need multiple operations to completely resolve. In the UK, we do 2 incision fasciotomy. The aim is an anterolateral incision, which would relieve pressure on both the anterior and perineal compartments, and a posteromedial incision, which would relieve pressure in the posterior compartments, both deep and superficial. Okay. So operative management of tibial shaft fractures. You can see here, we've got a highly comminuted tibial shaft fracture, and there's also an associated fibular fracture. This X-ray actually emphasizes the importance of having 2 views. On the AP, the fibula looks like it's not very comminuted, although this end should be up here. You can see that on the lateral film, it is much more comminuted than it looks. Okay, and this needs to be reduced, and you have a spiral fractures here. On the right-hand side, you can see how they fixed it. They fixed it with an open reduction internal fixation technique and plating. So on the fibula here, you can see there's a lag screw. So this is just a screw going across the fracture line to fix it, and then a long plate along the tibia. Okay, and that is to reduce the fracture. Again, you have lag screws in there to close the gap between those 2 fracture segments. You can also do intramedullary nailing for these patients, and this is particularly useful with multi-fragment comminuted injuries or where there's loss of height. Okay, this technique means that the patients can usually weight bear immediately after the operation, and these nails can stay in long term. Okay, so here it's a weight bearing nail, so it bypasses the fracture and allows that time to heal. Okay, and it stabilizes everything. Next, we have external fixation. So this would be the treatment of choice for those open fracture patients we saw earlier. There's multiple types of external fixation, and those will be, you'll learn at a higher level. Most of them will be fixing above and below the fractures to allow healing at the fracture site, but also it means that you're not introducing metalwork into what you believe is already a contaminated area, and so reduces the risk of infection of metalwork. I've shown you this AO diagram to make it a bit more obvious. As you can see on the x-rays, it's actually quite hard to see where the fracture is with so much metalwork in situ. You can see here, there's a gap where there's been bone loss high in the tibial shaft. Okay, it also looks like there's some bone loss developing here, which may be due to a loss of blood supply. Okay, again, you can see another x-ray. This is 6 months after follow-up. There's some callus formation here in the mid shaft, which is what we were looking at on the left, suggesting that there was a fracture there too. Okay, and it's all healing quite nicely. The IM nail also provides relative stability, okay, of the joint. So there is some movement at the fracture, but that actually allows secondary healing and callus formation, which is what you see in these. Okay.
All right, I think we'll leave it there then. Thank you very much.
Thank you.
Thanks, Jay.